Good afternoon, everybody. I'm really privileged and glad to be here to present our survey on the community-based HIV prevention on a program run by the peers of the female sex workers population in Yangon and Mandalay. This is the background of the study. And in Myanmar, HIV is in a concentrated epidemic within the key affected populations such as female sex workers, men who have sex with men, and people who inject drugs. And the population prevalence among these key affected population is way up high compared to the general population, which is below 1%. For the female sex worker, an estimated 9.4% of the female sex workers in Myanmar are HIV positive. And there is prevalence of the risk behaviors like inconsistent condom use and low HIV testing rates and so on. So, as a part of our PSI, we have run a program called Targeted Outreach Program, TOP. We ran centers, drop-in centers called TIC, in our country, in 18 towns and cities around Myanmar. And we use community-based approach using peers, and they are promoting HIV testing and condom use among their peers, which are FSWs. And as in 2013, a PSI TOP program has reached over 20,000 FSW with HIV prevention services. But the thing is, that is reach. Reach is just, as the previous speaker said, it is all about the numbers. So our question is, does it have any effect on the affected populations? So we try to answer that question, and this is our study objectives. Our objectives are to measure the proportion of FSW who reported getting tested for HIV. We are promoting HIV testing, and we try to measure how successful we are, and we try to assess any relationship or rules the TOP has in promoting this behavior. So our study design is a cross-sectional survey using time location cluster sampling among the study population of women who reported having sex with a man for many in past 3 months in Yangon and Mandalay. And we studied them about 3 months, the study periods. And for the results, we have used a matching method called cause-and-effect matching to improve the accuracy of the results in assessing the effectiveness of the TOP program. We try to match 2 groups who had ever visited TOP TIC and those who never did. And we try to match these 2 by using cause-and-effect matching. It's an imbalance matching method designed to reduce imbalance between 2 groups of exposure in observational data. We don't really have any case control or random matching, so that's the best we can get, and we try to match these 2 groups as best as possible about the exposure up to the top. And we use 2 matching criteria: the location where the clients are met, maybe streets, brothels, or bars, or massage, and so on, and then their current city of residence, like Yangon or Mandalay, and we analyze them using standard version 11. And then, from this procedure, we have weights, CEM weights, and we use that weights in the logistic regression procedure for analysis. In here, our exposure variable is the TOP visits, and the outcome is HIV testing, that's the primary variable, and then STI checkup and treatment within the 12 months. And we also adjusted for covariates in the logistic regression procedure like age, education, duration of sex work, and the presence of regular partners, which may affect the HIV testing rates. In essence, we are asking whether the visits to TOP and DIC have any effect on the HIV testing. And these are the results. In the population, 72.9% of the female sex workers said they had ever tested for HIV, and 64% said they had tested in the past 6 months. And among these, the positivity rate is about 14%. And that's pretty high. And about the STI, 39% said they have received STI checkup within the 12 months, and then 31% said they have received any treatment. And these are the visits to our top TIC. 38% of the respondents said they had ever visited TOP, and then among these, around 75% said their first visit was more than 4 months prior to the survey. And we asked that specifically because we reckon that if the visit is too near to the survey, it may not have any effect on the testing. That's why. And this is the results of the influence of top TNC visits on HIV testing. And you can see the adjusted odds ratio here, 3.96, among who ever visited top TIC compared to those who never did. So, women who ever visited top TIC were 4 times more likely to get tested for HIV. And that's a very promising result. And also, about the STI management, about the STI checkup, women who ever visited top TIC are 3 times more likely to get STI checkup, and then they are 8 times more likely to get STI treatment from a qualified provider. So, our conclusion here is that our targeted and community-based HIV testing services through top centers are working well, and they are increasing the likelihood that women who work for sex work get tested for HIV and get other services. So, in here, we should consider scaling up these services to get a wider coverage. As you can remember in the previous slide, only 30% or 35% got these services. So I'm here to advocate for scaling up of the community-based testing services and the better access to reach the harder to reach and the hardest to reach groups. Thank you.